Alrighty, well, welcome everybody to webinar number 4, Interprofessional Care, Discharge Planning, Community Engagement. Really excited to have y'all here today to talk about this. This is part 4 of our webinar series where we've been sharing information and best practices about the hospital-based treatment of opioid use disorder. And so we're really excited to continue sharing some of our best practices and lessons learned. This particular session is really exciting for me to present whenever I get the opportunity to, because what we're really going to be doing for the most part today is talking about the program that we created at Dell Medical School in Ascension, Texas, the B-Team program. So I get to brag about the amazing people that I get the privilege of working with every day and sharing with you a little bit about our journey for you to learn from. So let's get to it. I've gone ahead and enabled everybody's audio. We will ask you to stay muted for now, but when we get to the Q&A, feel free to unmute, or of course at any time during the session, you can use the chat box, you can use the Q&A box, whatever way is most convenient for you to communicate with us. All right, let's get rocking and rolling. I have nothing to disclose, and today we'll talk mostly about describing current models for improved care for hospitalized patients with OUD, and then we'll talk about sort of how we started a medication for addiction treatment program at Dell Med and how that may apply to your institution. So let me give you a little bit of background about where I have the privilege of practicing. I work at our main academic center in Austin. We have about 210 beds, Dell Medical Center. It's pretty much a brand new hospital, opened just a few years ago. It replaced Brackenridge Hospital. So if you're familiar with Brackenridge, it was the heart of our safety net system in Austin and Travis County for over 100 years. They are actually knocking it down as we speak. I think it may actually be, they may have completed the demolition process. So the end of a journey for Brackenridge and the beginning of a new one for Dell Seton. So we're brand new state-of-the-art facility. It really is a privilege to practice there. But we are the primary safety net hospital for a metro area of well over 1 million people now, and continuing to swell every day. I heard a stat the other day that there's now 300 plus people moving to Austin every day, which is hard to believe, but I've read that in several places. The way that our system, as many systems across the country are, is we have the medical school, and then we have the not-for-profit hospital system, and they're separate entities. So the property that we all work on is owned by the University of Texas. The hospital itself is owned by Ascension, Texas. It's part of the Seton system here locally, which is the largest national nonprofit hospital system in the country that has a religious affiliation. And then literally the opposite side of the street, you could throw a rock and hit the health learning building of Dell Medical School. And so we work extremely closely together. We collaborate closely together. When I first came to Austin, I was actually employed by the hospital system, and then our division of hospital medicine sort of transitioned to be under Dell Medical School. But as you can imagine, there's so much close collaboration that happens between these two organizations. We really are sort of one big family. And because we're an academic center, of course, we have not just GME, we do have a very robust graduate medical education program. Dell Medical School, which is relatively new. I think we are just about to graduate our second class of med students, which is really exciting. But our GME programs have been here for decades. They used to be affiliated with UTMB in Galveston, and now obviously that we have a medical school here in Austin, they're affiliated here. So even though Dell Med is relatively new, our GME footprint is large. And I forget the number, but we have something like 300 plus residents across all of our different programs, and we have well over a dozen established GME programs, all of the usual ones that you would imagine, and then actually some ones that I still learn from time to time, in particular around fellowships that we have that I didn't know that we had. So we have a really large GME footprint. Our UME footprint, I believe our class size is about 60 per class for UME. But this work really started as a large focus on readmission prevention. So I will be honest in saying that 4 years ago, when we went on this journey of increasing access to buprenorphine during hospitalization, it was not necessarily through the lens of let's improve care for people with substance use disorders. It was really looked at as seeing our readmission data, knowing that people with intravenous drug use were, especially at our institution, at high risk for 30-day readmissions. And for anybody who works in the hospital setting, of course, one of the holy grails of practicing in a hospital is readmissions, in addition to length of stay and HCAHPS and all of those things that really matter to hospital systems and sort of the metrics that we work towards and work to. And so when we saw that we had a high degree of readmissions for people with intravenous drug use, and coupled that with the appreciation that we weren't actually doing a lot for those patients in terms of their substance use, that we were treating the reason for admission, which was often the skin and soft tissue infection, for example, but that we really weren't doing anything for the underlying issue, which was the substance use. So this really started as a quality improvement intervention. And of course, what we've learned in the process over the last several years is that this really is so much more than a quality improvement project. This is really a way to influence practice in a way that is sort of win-win-win-win for everybody, right? Certainly for the patient in terms of increasing access to evidence-based care, but also for the health system in terms of costs, readmission, et cetera, and for members of the healthcare team, not just physicians, but nurses and social workers and pharmacists, all members of the care team who care for people in the hospital, including people with substance use disorder histories, giving all members of our care team tools on their tool belt to really act in the patient's best interest, which is not something that we have done in hospitals across the country, and of course, including Texas. And so really, this has been quite a journey for us, and that's what we'll talk about today. Okay, so our problem statement, I mentioned earlier, this was a quality improvement project. And so, most quality improvement projects have some sort of, problem statement. And so this was ours. How can we go about treating hospitalized patients? So when we started doing this, we were very focused on inpatient medicine, right? So hospitalized patients, not patients in the ER. So when patients are admitted to the inpatient service, how can we treat them, right? Patients who have opioid use disorder at our 200 some odd bed academic hospital, academic medical center, without the presence of a formal addiction medicine service, right? So we did not have a group of people that we could sort of turf this to. I often talk about this concept of NIMBY, not in my backyard, where most people in society would argue that, yes, I agree with increasing access to treatment for people with addiction, but there's always this sort of argument about where does that access live? And so people say, not in my backyard. I support it, but not in my backyard, not in my clinic, not in my city, not in my hospital, not in my discipline. And so often this ends up being siloed within psychiatry. This ends up being siloed within behavioral health. It ends up being siloed within, outpatient opioid treatment programs or OTPs, which are really designed to treat substance use disorder, oftentimes solely opioid use disorder, but don't provide any sort of, wraparound holistic kind of primary care. And so we've created this sort of siloed system. So at our institution, we have a wonderful consult liaison psychiatry service, but we do not have an addiction medicine service. And for those of you who also work in safety net hospitals who have a CL psych service, that is often an extremely busy service, and they work with a wide array of behavioral health and psychiatric diagnoses well beyond substance use disorders. And in terms of acute hospitalization, their attention is often required on some of those more severe, acute, psychosis, so forth and so on. And so they don't necessarily have the bandwidth to contribute 100% to substance use disorders, right? Because their scope as CL psychiatrists is just so much broader than that. And you'll hear a little bit in here about how we did partner with our CL psych service, but the fact remained that at the time we started this, Nobody in our hospital was starting buprenorphine. Nobody in our hospital had the X waiver. Nobody in our hospital was coordinating outpatient care or discharge care after hospitalization for opioid use disorder. And that included our CL psych service, right? So nobody owned this. And so the question was, how do we basically empower people who are already working in the institution? And that really is exactly what we did. That was our solution, was to look at our institution, to look at people who already work in the hospital and figure out how we could empower those individuals who may have an interest in this topic area. And so we empowered these existing teams through the creation of what we called, very original name, the buprenorphine team, or the B team. And actually this ended up working out in our favor, because the joke ended up being, well, how come you guys don't call it the A team? And so it kind of gave us a little bit of a humorous platform to share more about our work. So we created this B team. This is a picture of the group. We actually have a more recent photo. But what I want to tease away from here is that this is a interprofessional and multidisciplinary group. So the only way that we can truly make progress on substance use disorders as a whole, whether it's in the hospital or in the outpatient setting, is through a interprofessional and multidisciplinary collaboration. If you take nothing else away from the talk today, it is exactly that. This is a team sport. No one profession and no one discipline will solve our drug use epidemic in our country. So we all have to collaborate and work together. And that is, truly that is the if I had to pick sort of one thing that we are most proud of in our program, it is exactly that. And I'll certainly talk a little bit more about that. So what is this B team, this buprenorphine team? And before I kind of share this model with you, I should add that this is what worked for us. This is what worked for us at our academic center, our safety net hospital, our 200 some odd bed institution in Travis County, where we do have some robust outpatient mechanisms for buprenorphine follow-up. Not all of this is going to be plug and play at your institution. And that's certainly not the intention of today, is to say you must do this the way that we did it. The point of today is to show you how we did this at our single site in Texas, and then to work with you to sort of facilitate similar practice. At the end of the day, the goal, the intended outcome of all of this work, whether it's at our institution or yours, is to increase access to buprenorphine during hospitalization and facilitate follow-up to post-discharge care. That's the goal. And the steps that we take to get to that goal are going to look a little bit different depending on the institution. So I don't want you to think you need to like plop this into your hospital and then all of a sudden, that's how it's going to go. Because most likely, if we look at 5 hospitals that reach that end goal, they will all have gotten there on a little bit of a different path. So how do we do this? So one, as I stressed earlier, this is a interprofessional and multidisciplinary group. And the work that we do, we sort of put into these buckets. There's sort of a screening bucket, there's a treatment initiation bucket, there's a linkage to care bucket, and then there's this sort of education bucket. And so the screening piece has to do with raising awareness about opioid use disorder so that all members of the care team feel empowered and comfortable having conversations with patients about unhealthy drug use and unhealthy opioid use, but that they also feel empowered to reach out to this group, the group being the B team. So when we started this group, as I mentioned earlier, no one in our hospital knew much about buprenorphine. Certainly nobody was ordering it. Nobody had an X waiver. Nobody was prescribing it. The overarching mission was to create this group that would develop subject matter expertise about buprenorphine and then share that expertise with everyone else in the institution with the goal of making ourselves obsolete, right? Planned obsolescence is actually our mission, right? We want everybody to understand OUD, start buprenorphine on their own. It's really easy. It's really straightforward. It's much more safe than, oxycodone and hydromorphone ordering and prescribing. And so really, we feel strongly that everyone should just sort of do this on their own. Until we get to that point where everyone's doing this on their own, we're the interim step, right? We are facilitating that happening. And so we are empowering folks to sort of recognize opioid use disorder. And what I will caution you with about here, and I will caution you without having much of a solution, is what I mentioned in our previous session, is that there is no screening tool for the acute care hospital setting that has been validated around opioid use disorder. So for our program, we rely on sort of what I call the totality of clinical circumstances. So, one, there's sort of the very obvious patient with OUD, which is the patient who says, for example, is admitted with a skin and soft tissue infection. And when you're taking the history, the patient says, oh, I use intravenous heroin, right? So that's very clearly a patient who has an opioid use disorder. There's no sort of guessing there. There are patients who maybe have a skin and soft tissue infection, and on physical exam, you see evidence of intravenous drug use, but the patient doesn't admit it. That, obviously is not necessarily a quote unquote slam dunk diagnosis, right? But it raises the kind of question. But then there are those that are more challenging, right? There are those where our biases, and this is not a talk about bias, but I want to just be very upfront that when we do our work and we rely on clinicians for the most part to identify patients who may benefit from a treatment outside of the patient directly saying, I need help, then we leave that screening process to bias. And so I would argue, and our team would argue, that our current process actually does have bias, because there is no standardized screening process at any institution that I'm aware of that's been validated. And so in any of these workflows where we are screening without a standardized screening approach, you are inherently open to bias. So I want to tease that out. I don't have a solution for that yet, up until we get to a point where we do have standardized screening. And standardized screening, as we talked about in our previous webinar, there's a lot of challenges with that logistically in terms of who owns it, having administrative support, so forth and so on. Electronic health record integration, all of these things are big questions for standardized screening. And so I raise this problem to you without having a great solution, but just to really raise awareness that when we get to talking about our numbers, right? We've evaluated over 200 patients in the last couple of years. The number of people who may actually benefit at our institution is probably much higher than that, but we are left to this sort of quasi-screening method. So we are certainly, I am 100% certain, we are under-screening. And at your institution, you will probably under-screen as well. Now, the flip side to that, as I mentioned earlier, is before we started doing this, 0 patients were being identified, 0 patients were being started on buprenorphine, 0 patients were being linked to care. And so still there is benefit, but we do need to pay attention to the biases, and the particular bias that I and other members of my team are concerned about is, do we create unintentional racial disparities in not having a standardized screening process? So that is a research question that we're looking at, that we're actively looking at, but I want to raise this with all of you because it's certainly important. Okay, so that was a lot to do with screening. The point here is that we've done a lot of work around raising awareness with different stakeholder groups in the hospital about opioid use disorder. So prior to us doing this work, nobody talked about opioid use disorder. Now, people talked about, quote unquote, and I'm very intentionally putting this in air quotes, opioid addicts, right? Opioid abusers, right? It was a very negative connotation talking about anybody who had unhealthy opioid use. We did not talk about this as a clinical diagnosis and what can we as a hospital do when a patient may have this chronic medical disease, this opioid use disorder. So that all kind of fits under the screening bucket. And we've empowered our learners, our residents, our med students, our attending physicians, our nurses, our social workers to sort of have these conversations and sort of signs and symptoms to look out for. And even though this program lives in internal medicine, we have offered our services, if you will, to other service lines in the inpatient side, in particular, general surgery. In a perfect world, our general surgery attendings and our general surgery residents would have a degree of engagement in this similar to internal medicine and family medicine, where they're excited to start buprenorphine, they're interested in learning more about buprenorphine. That today is not the culture of our institution, and to be frank, is not the culture of most institutions, right? This type of program would be seen as a med consult type of thing to a general surgery service, and that's what we've done. That being said, there's been really great uptake from our general surgery colleagues. They recognize the importance of starting patients on buprenorphine. It's something like 30% of our consults actually come from general surgery. So they certainly have bought into the concept. And when I talk about planned obsolescence, there's certainly some hope of doing that with our general surgery colleagues as well. And in fact, the program director of our general surgery residency program is part of the group looking at requiring buprenorphine training and X-waiver training for our residents across the entire GME spectrum. Again, this stuff takes time. It happens over several meetings, so forth and so on. But of course, progress is what's key, and we're certainly seeing that. Okay, that's all about screening. Once we have identified a patient who may benefit from buprenorphine therapy, there's this intervention, this initiation process. And this looks different today than it looked 3 years ago. So let me tell you how it looked 3 years ago, and then I can kind of tell you how it looks different now. So 3 years ago, we had a very small group of people who have built subject matter expertise around buprenorphine. That picture I showed you earlier, that's a recent picture. The team was not that big when we started doing this. It was myself, it was our chief of CL psychiatry, it was an advanced practice nurse with our palliative care service, and it was a PGY2 internal medicine resident, who, by the way, is now our chief resident and is going on next year to Yale's addiction medicine fellowship program. Super exciting. Nick Christian, by the way. So it looked different then. So we had this very small group of folks who had spent a lot of time reading the literature, talking with experts across the country who had built these sort of hospital programs. And so we did a lot of education up front, but this is very much a sort of see one, do one, teach one type of thing. And so we can talk about it all we want until people actually see it and then actually do it with some sort of mentored assistance. Then the uptake is just not that strong. And so early on, 3 years ago, somebody would identify a patient as maybe somebody who would benefit from buprenorphine. They would reach out to us on a secure texting platform that we have in the hospital. So they would just text us and say, hey, John or Jane Smith in room 550 might benefit. And then we would go and see the patient, and we had a whole intake form that we would sort of ask all the questions. And I mentioned this in a previous webinar that, if you're super limited for time and you can only ask just a handful of questions, when it comes to starting buprenorphine, the most important questions to me, and this is not an official guideline, this is not evidence-based, if you will, this is Rich Botner's practice, is what substances does a patient use? How much of each of those substances do they use? How frequently do they use each of those substances? And then the fourth, probably most important question in relation to starting buprenorphine is, when did you last use? So that, we would go to the bedside, we would kind of have these conversations with patients, we would provide counseling, and whenever possible, we would bring the team with us, right? We would bring the primary team with us, we would bring the bedside nurse with us, and we had champions in each of these disciplines. So within our first month or two, we brought in a pharmacy champion, we brought in a nursing champion. And so it was that person's responsibility to try and do some kind of just-in-time quick training with all of these members of the staff. And again, these were like quick, 2-minute interactions. We would print out the COWS, algorithm, and we would quickly go over it with the nurses. And then we would always end with, here's my cell number, here's my, how you can reach me on Tiger Text, which is that secure platform. And so we made sure that people knew that if they needed help, that we were available. And of course, in reality, very few people needed help because buprenorphine is really straightforward. But when you've never done something, there's just that little bit of angst that goes along with it. So we did all of that just-in-time training, and then we have a chaplain on our team who meets with patients and does his best to provide psychosocial, spiritual support. And gosh, I've learned so much about what chaplains do and how amazing they are Of course, it is so much more than kind of just a religious intervention, right? Evan, who's our chaplain, is so incredibly helpful with patients. And since we started this program now, not 3 years ago, 4 years ago, we now have a peer recovery specialist who also meets with patients. So all of this happens in the kind of the early part of the hospitalization. But at the end of the day, today, right, 3-4 years later, we've done all the education. We've been doing this clinical work in the hospital now for all of these many months. Pretty much all of our attendings, all of our nurses, all of our pharmacists have been involved either directly or very closely indirectly with at least one patient who is either started on buprenorphine or is on maintenance therapy with buprenorphine. People are familiar with this. People can pronounce it, right? When we first started this, nobody could even pronounce the word buprenorphine, but now it's a standard part of our care. And so now the degree of kind of hand-holding that we do is much, much less. And in fact, for internal medicine in particular, starting this past January, we completely changed our approach intentionally. We did a whole noon conference with them, and we said, from now on, we are not going to the bedside. Let us know when you have a patient who may benefit. We will review the chart. We'll talk with you about the patient over the phone or through that secure texting platform, but you're going to order it. You're going to follow that patient. You're going to have the counseling interactions. And of course, we did this with support of our GME program and our hospital medicine leadership. But the point is to make this a true standard part of our care. And that's exactly what's been happening. I'll give you an example. Literally this morning, got a Tiger text from one of our internal medicine residents who's on their medical ICU rotation. They have a patient who's been off of their buprenorphine for about a week, and they want to restart it. They reached out and they said, this is the situation, kind of this is my plan. What do you think? Kind of went over the case, and they went forth and conquered. And we did not see that patient at the bedside. There was no reason to, right? Okay, then there's the linkage to care. There's the piece where we have built relationships with outpatient, OBOTs, office-based opioid treatment programs, and we've developed a system and approach where we can reach out to that clinic and we can connect patients to care when they discharge. So we don't even call it the warm handoff, we call it the boiling hot handoff, because we've really built this great relationship to the point where we can just call them, they have my cell number, we have their numbers. I mean, we're all very, very closely connected. Now, that's where you want to get to. I don't want to fool you. I don't want you to think that this took, that this happened overnight. This happened over time. And there were mistakes that we made in the process. And I think everybody was on the same page that we were learning how to do this, and that, we may drop the ball here and there. But the goal was to create a pipeline for improving patient care and patient outcomes. And as long as everything that we were doing, all of the decisions that we were making were rooted in that, we were able to kind of build this collaboration. Again, so it took some time. It didn't happen overnight. I would argue that, most communities, especially communities that sort of surround urban or even suburban areas, have OBOTs. They have buprenorphine prescribers, right? The rural communities are a little bit more challenging, and we could talk about that a little bit later. And hospitals have a unique role in being able to lead some of that systems shaping and systems building in their community. So I will tell you, the community clinics that we refer to, they didn't come knocking at our door. We went knocking at theirs. We figured out who they were. We learned about what they were doing, and then we reached out to them and said, "This is what we're trying to do. Will you work with us?" And of course, for them, there was an advantage to doing this, right? It becomes a referral pipeline for that clinic. And so it was a really effective, partnership that we built over time. All of our patients leave with naloxone, super important. And then again, we have that peer recovery piece. And then, as I mentioned, we do a lot of education. When I say education, I mean that as formally and as informally as possible. So did we do noon conferences and sort of 1 hour traditional lectures with our residents and our med students? Absolutely. But did we also go to the boardroom and have a 15-minute presentation to hospital executives about what we were trying to do? Absolutely. Did that presentation look different than the clinical one that we gave to our residents? You bet it did, right? It focused on the quality improvement part of this project, on readmissions, on cost, those types of things. Did we go to the Patient Family Advisory Council and present to them what we were trying to do? Of course we did. Did we go to the philanthropy and donor group of the hospital? Sure. Did we ask for money? No, we did not. But it was helpful for them to appreciate what the hospital was doing to engage around issues that, that affect our community. And so that group was super excited to learn about what we were doing. And every time we had one of these touch points, there's a great book, by the way, called exactly that, Touch Points. And the whole premise of the book is the more you talk about something, no matter who's listening to you, the more you build on the work that you're trying to do. And that was certainly the case here. So when I say education, I want you to think about it broadly. The opioid epidemic is a top priority. It's a hot topic, unfortunately. And so there are really no shortage of places that you can go within your institutions to talk about this where that audience will want to listen. You may have to tailor the message, but this is an important issue that people care about. And so the more you talk about it, the more you get adoption over time. And that's really exactly what happens. It starts to snowball. And again, as I mentioned earlier, we did all of this without an addiction medicine presence. So probably one of the questions I get all of the time is, how much did it cost to do this? And I have to tell you, I still haven't figured out a great way to describe this program that doesn't make it sound like it cost a lot to build, right? We call it a program, we call it a consult service. It's really not either of those in the traditional sense. There is no cost center for this. There's no FTE allocation for this. This is a group of volunteers who were passionate about this, who invested some of their own time, some more than others, and then helped to build over time. Now we've got, well over a dozen people in our group. Before we had 3 or 4. And again, with that planned obsolescence. So, I have grant funding from Texas Health and Human Services. And so now there is some funding towards this, but most of that funding goes toward this work, towards the dissemination work, not towards the actual clinical service delivery. Actually, none of that goes towards clinical service delivery. And so that's a really important point that I want to share. Okay, just to give you a sense of who's involved in this team and all of the different disciplines. I mentioned earlier, this is not just an internal medicine thing. This is internal medicine, this is nursing, this is pharmacy, it's social work. We have learners, we have med students, we have residents. We have folks from palliative care and psychiatry. We have a chaplain, we have a peer recovery specialist, we have a data analytics person. And again, this took some time to build. We didn't come out of the gate with all of this. But this is where you want to be. You want to engage as many different people in the institution. And of course, we have folks on the kind of periphery who maybe aren't, part of the team every day, but people we can lean on, right? People who work in information technology who can help us navigate the EHR, people in leadership, right? Our executive sponsors, so forth and so on. So let me pause there for a minute, take a quick drink of water. And let me tell you a little story about the very first patient that we ever started buprenorphine on or for. I mentioned earlier that we spent a lot of time going over all the literature, speaking with experts across the country. Part of why I'm so excited that we have this funding from Texas HHS to bring this programming to you is because the year plus that it took us to get this right, you can skip that part. And a lot of that research that we did early on was because we were sort of nervous. We were afraid. Now today, lots of people are talking about buprenorphine, right? Even 4 years ago, that wasn't the case. We were the first hospital in the entire state to do this. We were, as far as I know, one of very few, if not the first in the South to do this. And in hindsight, it seems so silly because what I know now is buprenorphine is safe. It's a very straightforward medication to start. It's an incredibly beneficial medication for many of our patients. And it's certainly, when you look at risk benefit for patients with opioid use disorder, the benefit versus the risk is far better than, oxycodone and all of these other medications that we prescribe at will. So in hindsight, all of the angst around, initiating buprenorphine was for naught. And I really want you to take that away because as soon as you see your first patient and start buprenorphine, you're going to go, oh, that was really straightforward and easy. But nonetheless, we had been in so many meetings. We had, I mean, just dozens of meetings with administration, with our outpatient clinic, with internally, and we still hadn't started our first patient on buprenorphine. And I got a phone call from one of our nurses, and they said, "Can you please come see this patient? We're about to do an administrative discharge for this patient, and I really hope can you do something? I heard you were starting this program about buprenorphine." Actually, that nurse probably said it around treatment because nobody could pronounce it at the time. And so I went to go see this patient, and he was really upset. He was sort of throwing things around the room. He was very upset. He was screaming. And what most of the staff heard were screams, just sort of loud, agitated patient. What I heard were the words that the patient was using when he was screaming, which was, "You don't care about me. I'm withdrawing. Nobody cares about my drug use. All you care about is my heart." This was a patient who was admitted with endocarditis. And so when I got more of the story, it turned out that this patient had left the hospital overnight, didn't tell anybody, kind of snuck out, had purchased heroin on the street, and then came back into the hospital. And of course, that's a safety concern, right? And so this had gone up the chain of command to hospital leadership, and they basically said, "That's unacceptable. This patient can't stay here. We need to administratively discharge this patient." And I'm not blaming by any means our hospital administration, right? This type of situation happens across the country on a daily basis at dozens, hundreds of hospitals. And that is typically the response when you look at the risk on the hospital for that type of thing. So I called our chief medical officer and I said, "Look, I understand this was a challenge, and our CMO was our executive champion for all this." And I said, "We're not ready to start buprenorphine yet." And I put that in air quotes because in hindsight, what does that even mean? We just didn't feel comfortable yet. What was going to make us comfortable? Who knows? All we knew is that it wasn't there yet. But I said, the nursing staff is concerned. They really feel like this patient needs help. They feel like this patient needs to be admitted. If I talk with this patient and we get buy-in from him to start buprenorphine, will you reconsider the administrative discharge? And he thought about it for less than a second, and he said, "Sure. If this patient will start on treatment, we'll sort of give one more chance." So I met with the patient. I sat down next to him, sort of eye level, and asked him about his history, asked him what we could do to help, told him, my understanding of buprenorphine and what I think it could do for him, and asked him if he would start that medication and then, stay with us. And he agreed. And so we did our just-in-time training. We got all of our little algorithms out that we had all gone over. And, of course, we had our pharmacy champion and we had our nursing champion, and we were all sort of like, wading into the water. And we placed the order. Patient got, his first dose, and this was kind of late in the day. So I went home after this, and of course was up all night, like calling the nurse, how's he doing? How's he doing? Everything sounded like it was going okay. He got his, second dose, maybe around 8 or 9 o'clock at night. And I went back to work the next day, and I went to go see him, pretty much right away. And I heard singing music from the other end of the hallway. And so I went down to his room, and I mentioned, we're in this beautiful new hospital. Most of the patient rooms have these big picture windows that overlook downtown Austin. And I kind of poked my head around the door frame, and he was, sitting, like lounging on the little couch that's by this big picture window. And he's playing the air guitar, listening to rock and roll music, completely different person than the person I saw before. And I went to go see him, and he was so incredibly grateful that there was this group of people who cared about him as a person, not that he had snuck out, not that he had this history of incarceration and drug use. That we looked at him as a human who was asking for help, and we met him where he was at, and we advocated for him. And he had endocarditis, so he ended up staying in our hospital for about 5 weeks. Had a tremendous 5-week stay, no more behavioral issues, extremely appreciative to all of the staff, really a wonderful patient that any nurse or care team would want to take care of. And so at the end, he said, I want to do something for you. I said, no, you don't have to do anything for us. But I got to know him during his hospitalization. I knew he was a really good artist. So I said, okay, fine. If you want to do something, draw me a picture. Draw a picture of what it was like kind of before and after this medication. And at the time, we were very focused on the medication. I will tell you, it's not about the medication. Medication is a piece of it. Obviously, this whole cultural piece is equally, if not more so, important. And so he drew this picture. And so on the bottom left corner is him, sort of in despair. 3rd Street, when this gentleman grew up, was a particular part of Austin that was dangerous, and that's where he grew up. So that's kind of him in despair on 3rd Street. And then if you go counterclockwise, he drew the mass because the mass of addiction, and every time he used, he didn't know what kind of person he would turn into. He drew the die because he never knew if when he used, it would be his last. Because the substances may have been mixed or laced with something. He had been using for over 20 years, in and out of jail, and so he had the stopwatch from all the time that he had wasted. But then through the darkness of his substance use disorders, the clouds that you see there, the bright spot, the sun, was being at our hospital. Who would ever think that being in a hospital would be the bright spot? But for this gentleman, he had been in and out of hospitals so many times, including our own, and none of those times was he treated as a whole person, as he would describe. And so the bright spot in all of this was meeting our whole team, was being listened to as a person, was not being looked at as a problem, but as a patient deserving of care, and then being started on buprenorphine and being linked to care after discharge and all of those things. So I share this story every chance I get because, one, it was our first patient, right? And so what a wonderful outcome for our first patient, but two, because I think it shows the kind of impact that we could have been having all along, right? And again, as you heard me talk about in our first talk, I was one of those prescribers, providers who did not treat this patient population as well as I should have. And gosh, do I wish I had a time machine, right? These are the kinds of stories, these are the kinds of narratives that we can share, that we should share. And when we think about sort of the launch point for all of this at our hospital, it was this, right? We were not ready. Again, I put that in air quotes because I don't think we would have ever been ready. So I'm actually happy that this happened. But once this patient had a successful initiation, once he drew this picture and we started sharing this picture, the word spread like wildfire. And all of a sudden we were getting consults. We were getting phone calls from nurses. We were getting phone calls from residents. Hey, this bupropion medication, right? Because that's what everybody said in the beginning. We heard that this is helpful. We heard you have connections to clinics in town. We heard you know about a treatment and that you have a way of sort of talking to patients. And of course, we didn't have a magical way of talking to patients. We just treated them like patients. We treated them like people. And so that's kind of what started all this. And so it snowballed, and it snowballed for us. It will snowball for you. Once you start developing this culture and start shifting your standard of care, the rest sort of just comes along with it. So kind of, does it work? Does all this stuff work? I am so excited. This is the first group that I've actually shared this with. So yesterday, May 19th, 2021, we had our paper come out in the Journal of Hospital Medicine with our 2-year results data. And so you can get that online, or we will certainly share it with you after that. And this is a very busy kind of slide, and I don't want to bore you to tears with data, but just to kind of walk you from the left to the right here. So in the last 2 years, we have been asked to see over 250 patients, right? 260 patients. Of those, about half of them were quote unquote eligible for buprenorphine therapy as a hospitalized patient. Now, ineligibility for the most part does not mean the patient wasn't eligible for buprenorphine. It actually means that, one, oftentimes they did not have opioid use disorder at all. And so one of the things that you'll find when you start doing this work is people are so excited. People that work in the hospital are so excited to have a tool on their tool belt to help patients that you'll get phone calls for people with methamphetamine use disorder, with cocaine use disorder. You'll get phone calls for people with use disorders outside of opioids asking if buprenorphine can work, right? And of course, the answer is no. Buprenorphine is only indicated for opioid use disorder treatment. So many of those early consults, those patients weren't eligible because they didn't have OUD. Other times we would get consults from patients who had OUD, but were already on methadone treatment. already engaged in care at a clinic, not much that we can offer extra, right? If you're already in the program, you're in a program. And so those patients were ineligible. So those were some of the reasons for kind of ineligibility. But then, whoops, sorry about that. And then, so we started at 132 patients on buprenorphine. So all of the patients who were quote unquote eligible were then started on medication. And most of those patients were referred to the outpatient clinic. There's a small number that were not, and those were folks who were either discharged to a skilled nursing facility or were incarcerated and returned to jail after hospitalization. So 110 that went to outpatient. And then the big number to look at here is the number of patients who attended that initial outpatient appointment. So about 60%, 59% of patients. And when you look at other studies of hospitals that have addiction medicine consult services, that follow-up rate, that first follow-up appointment after discharge, it's about the same. It's about the same. Now, after that, you see it start to tail off. And if you look all the way down at 6 months, we are retaining about 20% of people in treatment. And again, that is also pretty much in line with what we see at other institutions. And so the bigger question for the system, not for your hospital, but for the healthcare ecosystem as a whole nationally, is how do we improve engagement in care? That's actually a huge part of what the HEAL initiative is studying, right? The billions of dollars that Congress passed a few years ago. But in terms of being in line with what other institutions are doing around the country that have dedicated resources, this is pretty much in line. Now, the caveat to this is, in a perfect world, I would say every hospital should have an addiction medicine consult service or an addiction medicine consultant. That's not a reality, right? Remember, this is only opioid use disorder, right? So there's still this kind of program. Now, we are starting to do alcohol use disorder work, but this type of intervention is really, it's a very targeted intervention for a very specific diagnosis. In reality, our patients, obviously, many patients have comorbid substance use disorders. And so we need to kind of be thinking about that too. All right. So what are the lessons that we learned in the 10 minutes I've got left here? Lots of information to share here. One, we learned that our initial focus was on medication, right? This whole program was designed around increasing access to buprenorphine, but actually it really was about, and we didn't know this at the time, but it was about helping people understand opioid use disorder as a medical disease and substance use disorders as a whole. So we reduced stigma by our education, by our messaging, by facilitating some of these challenging conversations. And as one of our attending physicians that's on our team now describes it, a role modeling, right? We built this group of people who role modeled the right way, the evidence-based way to care for people with opioid and substance use disorders. And when you have a group of people that's doing something a certain way and that's having success doing it, then others follow over time. And that's certainly what we have seen. So the bottom line is that we recognize hospitalization as a critical access point for people with opioid use disorder, and now addressing opioid use disorder is a standard part of our care. And remember, for many patients, for many people who use drugs, the healthcare system has not been kind to them, and they often do not enter the system until they have a life-threatening condition. And if they have a life-threatening condition, where are they entering the system? In the hospital. So the hospital is a really important access point for people. Substance use disorders can and should be managed in the hospital setting. Volunteerism, which is sort of what we relied on to build this, it really facilitated the work because the people who gravitated towards this over time they all self-selected, right? And so there was mutual interest, there was dedication, there was teamwork. As I'm sure all of you, you can't work in healthcare for too long before you either select yourself or are voluntold to participate in a team, right? So I've been on dozens of teams. I'm sure all of you have as well. This team is amazing. This is the best team I've ever had the opportunity to work with. And a huge part of it is because nobody was voluntold to do it, right? These were folks who were passionate about this, either because they were sick of the status quo, because they had a history of substance use themselves or in their family, and they wanted to give back. These are a passionate group of people, and they do really, really amazing work, all volunteer-based. So what are some of the themes that we kind of teased out? One is interprofessionalism. Internal and external stakeholder development was really important to do from an interprofessional perspective. So internal to the hospital, but also external to the community. Obviously we built connections with the local clinics, but we also did some advocacy work, right? We worked with our communications folks, and we had a couple of articles written about us in the local newspaper, and really tried to drum up some of the messaging around this being important. And every single time that we were successful in doing that was another opportunity to talk about the work. Again, we had those outpatient partnerships that we built. We had executive support from the very beginning. This is a sort of bottom-up, top-down, all hands on deck kind of situation. And then we did continuous and ongoing improvement. We tried to do PDSA cycles in the spirit of Institute of Healthcare Improvement. Easier said than done when you have a busy hospital service and you're working with volunteers, but we certainly did the spirit of it, right? We met regularly and we tried to figure out pain points and then work on improving those pain points. In terms of education, we learned a lot that kind of balance is key. In hindsight, we probably did a little too much education, because you have to balance educating so much that people get nervous that, wow, I keep going to all these lectures about buprenorphine. It must be because buprenorphine is, complicated or dangerous. That was one of the challenges of having the 8-hour waiver training, right? Was that it made it seem like it was this big, complicated thing, when in reality, it's not. Our education really was specific to OUD. That unfortunately has challenges, right? Because there are other substance use disorders that we want to be training about. And so again, balance is really needed there. And then we also have to be really careful on how we define admissions and hospital transfer. So early on in this work, not anymore, but early on, we would get phone calls from the ER saying, hey, this patient's here and they want buprenorphine. Can we admit them to your service? The answer is no. Right? The real answer is no, Mr. or Mrs. ER person, you should learn how to start buprenorphine. We do not admit patients specifically and only for buprenorphine therapy, because then we're a treatment center and hospitals are not treatment centers, right? We would get phone calls from other hospitals in our system saying, we have a patient who we admitted who has an abscess, they want buprenorphine, can we transfer them to your facility? No, you cannot transfer them to our facility. Same messaging. You need to learn how to start buprenorphine on your own. And so over time, this is exactly the messaging that we provided. Of course, I'm being a little bit facetious. We were much more collegial about it, right? And that's the direction that we're going. So we're always happy to provide counseling to help clinicians and other institutions do this work, including at our sister hospitals in our network. And that's how we've built our program. But you can imagine that hospital leadership, who was very supportive of this work, would probably turn unsupportive if we were transferring people specifically for buprenorphine. That is not something that can happen. And specifically because the reason you transfer to a higher level of care. And who's going to make the argument that buprenorphine is a higher level of care, right? Buprenorphine is a standard of care, not a higher level of care. All right. And then, we obviously had to work with some institutional and practitioner naivety to all of this. This was all 4 years ago, and that has much disappeared now. Just to kind of go over real quickly, we did do a process mapping exercise. Highly recommend this. Even if you don't do a traditional process map, this is a picture of our first process map exercise, and definitely helpful. But even if you don't do a sort of legitimate process map, getting in a room for an hour or two, locking the door, and just focusing on this one issue, turning off the pagers, turning off the email, and really just focusing on how are we going to work this out at our institution, critical step in the process. So highly recommend it, even if you don't do kind of a formal process map, although I recommend that too. We created resource documents. These are all going to be made available to you, that you can adapt them as you see fit. And then I mentioned earlier, we went everywhere and anywhere that would take us. So all these different types of meetings, and then many, many more after that. any group that would listen to us and listen about the work we were doing, that's where we went. And then finally, just kind of quick notes about our approach here to buprenorphine. One is that we had this sort of consultation service model that may have been the right or wrong answer, right? There's a lot that you could say about the consultation model. It made it harder and has made it harder to encourage people to do it on their own. As we all know, when there's a consultant available to do something, it's much easier to call the consultant than it is to do it ourselves. And so I think it would have been better had we encouraged people to take this on their own sooner, not in the beginning, but sooner than we did. We did not start encouraging internal medicine residents to do this on their own until we were about 2 years in. So that's too long, definitely too long. Trying to figure out what our method of communication was, we used secure texting platform. Figuring out what the role of telemedicine is in all of this. We did not use tele for this until COVID. And then when COVID hit, we were stretched on bandwidth, certainly for patients who were diagnosed with COVID-19 early in the pandemic, and we didn't really quite know about PPE and all of that, trying to navigate how we can start buprenorphine for them. We did roll out telemedicine in the hospital for that, and it worked great. And even today, we continue to sort of have a telemedicine component when it's feasible. And then, of course, the role of consult liaison psychiatry, super helpful for us in the beginning of our work, and continue to be extremely close partners and collaborators in this work. All right, I'm going to leave this in the PowerPoint deck for you all to look at. This is just an example of a checklist that we borrowed that will kind of just give you some ideas of things to look at and evaluate when you start a medications for addiction treatment program in your hospital. Again, I'm calling it a program. I really don't even mean to call it a program. When you start offering this type of service, I'm hesitant to call it a service too. But these are just some things to kind of think about. Our next session is actually, sorry, that's a typo. It's not May 13th, unless you have a time machine. It's actually going to be next week. And then our ECHO session starts on June 17th. Sign up for our ECHO. It's going to be a really awesome opportunity to connect with other folks across the state who are doing similar work to you. And so we're really looking forward to you joining that. I apologize, I talked so much, I didn't leave us time for Q&A, but I am happy to stay here. So I'm not going anywhere until everybody else signs off. You're all unmuted, so you can use the chat box. You can, oh, I saw now there's actually stuff in the chat box here. My apologies, I didn't see that. Let's see here. I see Alana has been answering all the questions. Awesome, thank you, Alana. I'm going to stay here and make sure there's no other questions. We are done for today, so feel free to sign off. But thank you so much for being here. And I'm going to shut up now. And if you have any questions, please feel free to put those in the chat box or the Q&A box, or you're welcome to unmute yourself as well. And thank you so much for being here.